perspective, and I think this is a view that we came to understand even more when Dr. Berwick was working with us, while we clearly have the greatest healthcare in the world and access to things unimaginable in a lot of the world, we are still looking to make improvements around how we distribute those services and how we get the value from those services that we would like to have, and how are we taking care of our caregivers, both our healthcare professionals, people that work in the community, and even family caregivers to support them in their effort to make their lives work for them. So we're going to talk a little bit about today about what we see this future system that we would like to get to, which will move more from something that's built around the producer and the provider of services today toward more of a future-centered world that we see the patient really as the center and the organizing factor of the various pieces of not just their sick care, but their management of their wellness as well. And we do believe payment is an important part of what brought us to the less desirable place we are now in terms of the distribution of these resources, and we think we have an opportunity to make change in that area. And clearly one of the most important things from our perspective is the lack of transparency around how dollars flow and how wealth is really invested in resources around health. So from our space at CMS, we've got Medicare, obviously, a program for the elderly and disabled. We fund about 2/3 to a little more of the Medicaid program, which is care for people who are medically indigent. We have the Children's Health Insurance Program, which helps lower income but not otherwise qualified for Medicaid folks. And then in the future, we'll be working with the states on subsidies through exchanges. So, you're going to get to a place, well, we're already at a place where the majority of people in the country somehow are touching one of our programs. And so we've got a responsibility to use that leverage to get to the future state that we see. One way we do that is through a variety of incentive programs. We'll touch on some of those. One of those is how we attenuate our payment policy, because people tend to go toward those choices that are going to maximize their financial experience in a transaction. And then finally, we have some programs that are specifically focused on improving quality. One of the important lessons that Don Berwick brought to us that I think some of us in CMS initially reacted to with some skepticism is the notion that quality is cheaper. And I always like to use the advantage that when you look at page 2 of the New York Times, you always see the ads for the Rolex and the Tag Heuer, these very expensive watches, which Americans would typically perceive as the highest quality watches. Well, I bought one of those watches for my wife when I got this job because a couple of her friends had them, and she's very proud of the Rolex watch. But, if you don't wear it every day, it stops running. And every year you have to get it cleaned for $350. So it is a quality-made piece of work, but I bought a watch for $100 that sets itself every night from some satellite signal in Denver. It's powered by the sun, so it'll never need a net battery. It'll never need to go in for any kind of service whatsoever until it dies, which will probably be long after I've expired. And since it sets itself every night, it's exactly right. So we can get to a meeting, and people will say, well, where have you been? And I'll say, no, actually, I'm within 2 minutes of the time for this meeting. And that watch only costs $100. That's the kind of quality that I think we want in healthcare. Dependability, reliability, cost effectiveness. A service that costs more and comes from a fancier looking machine isn't any better. You can get a really great looking tanning machine that's really fancy, but it's not going to tan any better than standing outside. So when you're buying the service for a lot of people, I really think that the Casio watch example is what we want. So our direction then, this is familiar to a lot of people, this notion of a 3-part aim. The challenge of this being optimizing all 3 of these things at the same time, or at least holding 1 or 2 constant. And as Rick Gilfillan from our Innovation Center likes to say, we're only really interested right now in investing things that are going to either manage the cost problem or keep it constant while quality is improved. We know we can make things better by spending more money, but we don't have a lot of additional money to spend right now. And there is a sort of 4th leg of this, which is that thing I mentioned before about the caregivers. What's the experience of the process like for the physicians, for the people in nursing, for people in administration? All these people are a very important part of the play, and we have to keep a sense at CMS, are we making their lives harder? As a matter of fact, I'm instituting a program where I'm sending people from my office out once a quarter to different kinds of care settings to sort of experience what our stuff means to the people that are working behind the desk at the doctor's office or the nursing home. So on the payment side, a lot of people know about a lot of these things that we're doing, but I'm going to just touch on each of these things briefly. The first is our shared savings program. We're very excited about this. There's actually a new part of Medicare. Traditionally, we have the fee-for-service program, Part A and B, and then the Medicare Modernization Act reflagged our risk and drug products as Medicare Parts C and D. Now there's a Medicare program that is enshrined in law and permanent that's built around shared savings and accountable care organizations. They're specifically called Medicare Shared Savings Programs in the law, and we just stood up the first group of these in April, 27 of them. And these are organizations of physicians, and in some cases hospitals and other kinds of care providers who agree to come together, focus on those patients who choose to see them in the fee-for-service, freedom of choice model, and to the extent that they can generate higher quality results and perhaps savings on that population that they see, people who really choose to see them, we're going to share in those savings with them. It's a very exciting model. We've demonstrated this model through some work that we've done before, but we've just stood up that new permanent part of the program. And at the same time this year, we've also taken a flavor of that is considerably more aggressive in terms of the savings that are available and the targets that we've set for these folks in what we call pioneer accountable care organizations. We set up 32 of them this year, 6 of which are here in California, most of them in the South. We've got one in San Francisco, and we're also very excited about them. And they're already in their first performance period. I'm actually going to meet with the California pioneers and shared savings plans down in the desert on Saturday. I'm looking forward to that. And then there was a third leg of this ACO stool. We knew that we could get physicians to work together, say in Southern California, where you've already got delegated risk in groups that see managed care patients but also treat fee-for-service folks. But what about in rural places? What about places where the physicians aren't working together today? If we're not creating something that didn't exist before, we're not creating real change. But we knew that there is cost involved in creating an organization to administer the shared savings and manage the data. So we've also made funds available as a demonstration for a handful of startup programs. So we'll be able to see, how does an investment like that work? And then hopefully if it's demonstrated that it does work, there'll be other sources of capital for people that want to do accountable care in the future. So those are our 3 approaches, then the shared savings versus the pioneer program, and then our advanced payment ACOs that have also just started. Another thing that's very exciting that we're doing as a demonstration is moving more toward a bundled payment approach for a variety of procedures. And if you think about it, if in Medicare we have a continuum of pure fee-for-service where you provide a service and get paid a fixed amount for it, and then the other end of a continuum, a capitation payment for that patient, everything they need, you've got to do it under the cap. If you think about it, what we're doing with accountable care or bundled payments is trying to work the space in between that. Everybody doesn't want to be in a capitated program. About a quarter of the people in Medicare are. That seems to be fairly stable. We know if we reduce the payment there, that'll go down. If we know that if we pay too much, it'll go up. But we're not going to pay too much anymore because we don't have any extra money, as I pointed out before. So we need other approaches to consolidate episodes and pieces of care into a more efficient outcome-focused approach, and that's where this bundling approach will work, where we're asking providers to come to us and say, tell us how you would like to accept a bundled payment for an episode of care. So, for example, maybe you want to do this around total knee replacement. We could look at the total bundle from the time the person shows up with the pain in the knee until the time the rehab is over, give you a global payment for that, hold you to some quality standards, and then you've got the opportunity to make money if you could do it for less than what we projected, or we've got some shorter pieces of those episodes. I was at a conference the other day and someone pointed out that 80% of our Medicare medical costs might actually be attributable to about 200 episodes that we can identify. So there really are, as we know, lots of medical procedures that or episodes, events that have a fixed sort of beginning and an end and a fairly standardized set of activities that happen in between. And so we want to move toward more efficient payment there. Another thing that we're doing, and you get the sense here, we're doing a lot of new things. This is what I'm really talking to you about here, of course, is the Affordable Care Act, is an initiative where we've chosen a number of places, I think it's 1, 2, 3, 4, 6, 7 around the country, where we're going to work with private payers and establish a program where physicians who are working in a fee-for-service environment can get a monthly payment to manage the care of people who they see who have a chronic illness. And in case you haven't noticed, there's an awful lot of people walking around with chronic illnesses. The majority of the people in our Medicare program have at least one chronic illness, and I think about a third of them have 3 of them. And those chronic illnesses, when you add another illness, that's when that, pile of blocks falls over. You got to keep them managed, you got to keep them stable. But if you're the doctor and you only get paid when you see one of those people when they crash, what are you doing to remind them to take their bills or check their blood level and so forth? Well, you need a little, incentive, you need some compensation for that, and that's what we're going to be doing in this program. About $20 a month those docs will get, and then we'll study and see if that really did get results. And of course we know that it does, because this already works in Medicare Advantage, where physicians are typically paid by their health plans in this manner. They get better results. And getting those better results isn't just about saving money, it's about making the lives of these people much better. I've got an elderly aunt that 2 weeks ago we managed to move her to an assisted living arrangement. She was like living on her own, and the difference in her just after a couple of weeks of like eating 3 meals a day and having to walk down to the dining room instead of sitting in her house by herself, it's like a huge difference from knowing she's a different person, she's happier. There's no point in being alive if you're not happy and thriving, and so that's what this is all about for me. There's some data in here about exactly how this works, but you can sort of imagine if you have predictable payment, you have the information to manage what's being done in the practice on those people. We're looking for places where the health IT exists to do that, then we can seriously look and see that we're getting the kind of results that we need to have. We are, after all, the stewards of the taxpayers and the beneficiaries' dollars, and we have a responsibility to make sure that we're producing results. Without information that can be aggregated and studied, we have no way to make that case, and so that's what we're trying to do there. Another exciting place where we're going under this law that is a path that we began back in 2004 under the Medicare Modernization Act is putting hospitals on a program of value-based purchasing. Back in 2004, we told the hospitals, if you'd like to get your update, your payment increase this year, you've got to voluntarily report quality data, and instantly 90% of the hospitals did that. Well, now we're up in the game, and now we're saying it's not good enough to just produce the data, you've got to produce results. And you may have noticed some news stories just in the past couple of weeks about some of this information that we've just begun to publish, because now on our website you can look at the Medicare expenditure per patient for all the hospitals in the country and see which hospitals are doing a more efficient job. When you put together what they're spending with the results they're getting, are the patients satisfied? Does somebody come when they ring the call bell? What kind of results are you getting on infections in the hospital? And then you put together a picture about, is this hospital performing or not? And that's exactly what we're doing in our 2013 hospital value-based performance domain. So we're already collecting this data now, and beginning next year, and next year is October 1st for us in the government, hospitals' payment will be attenuated around their performance on these measures. And the majority of those are measurable clinical processes of care, but a full 30% are based on these measures that we do by surveying patients across hospitals. So this is the transparency I'm talking about. These folks are running a business, they're getting paid by the taxpayers, by insurers. They need to do the job, and they need to be able to demonstrate that they can do the job. And we think that we're the only people that are really in a position to do that, because we've got the information about all these institutions, and we have no tie to any particular one or the other. We want all the hospitals to succeed. We want to be in Lake Wobegon. We want everyone to be above average. And we know that can't be the case, but if people don't know how they're performing, they can't improve. So we're moving in that direction. On the delivery system side, one of the things that we're most excited about is our partnership for patients, where we're investing $1 billion to stop preventable errors in hospitals and reduce readmissions. Right now, we've got 20% of the people with Medicare who get discharged are back in the hospital for the same problem in 20 days. This happened to my aforementioned aunt who threw a DVT in her leg, had a clot. She falls, ambulance takes her to the hospital for the clot, spent a couple days in the hospital, nursing home, you got MRSA when you're in the hospital, and you're back in the hospital, 2 weeks in the hospital, then a long convalescence at home, and now finally she's doing the assisted living and she can walk again. Well, we think we can cut that down substantially, and we're making an investment do that, having people come to us with programs for us to fund that work. At the same time, we're trying to reduce the preventable errors. About a third of the Medicare admissions result in at least one thing being done wrong in the hospital. And unless you get too worried about that, I think most of the time this is probably something that you wouldn't notice. Unfortunately, sometimes it's something you would very much notice. So we know that with respect to some of these particular problems, there are hospitals that get it right all the time. So the question is, how do we take the practices that make it right all the time and get those happening in the providers where they're not getting it right? And so what we're doing here is funding people that can put those practices together into a program that can be exported to other providers. So we're happy about that. We're trying to make hospitals truly safer, and we're working with lots of partners around the country and hospital networks to make this happen. Another major initiative for us, this Millions Hearts campaign, is very important. We're trying to prevent heart attacks and strokes, and this is an area I know that relates to some of the stuff that folks here are working on. Some of you probably know Dr. Saxon down at UCLA, the work that she's just published about how people with connected heart devices have better results after 5 years. There's lots of opportunity, I think, around cardiology, because this is one of those places where there are a lot of defined procedures and fairly predictable outcomes. It occurred to me, and I'm beating my Aunt Nancy to death, I should have her picture in the slides, but this is probably what's going to get her. Her problems all started because of this AFib she has, and now she has the congestive heart failure on top of it, and managing the blood thinners and so forth is very challenging. Lots and lots of folks don't understand how important this is, especially for women, because we're always reading about breast cancer and these other things, and they're very serious things, but there are also many of those things are people that survive, and in the end, the ticker is what matters. So, when I get up and do my jog in the morning, I don't think about now, I think about when I'm 80, and when I'm thinking about assisted living, and I don't want to be somebody that can just make it down to the dining room. I want to be the guy that's out, jogging around looking like a silly old fool at 7 feet tall and 80 years old. So we're very interested in this. Lots of opportunity around this that you need to keep an eye on. We've also made a big investment in innovation advisors. We went out and looked for people who can help us spread this innovation around the country at different institutions, and what we do is we pay a stipend to their employer to free them up to do some of this important work. We've already named 73 of these people. There are going to be 200. There is information on our website about this program if there's people here that are actually doing that, or you can just see me because they ask us to recommend people as well. We also recently announced a number of winners of our Innovation Challenge. This is where we've just asked people to come to us with programs and ideas. They're going to improve service delivery or reduce costs or make care better. And we just funded a batch of these. I think I have the numbers on this page, yeah. And I think there were 27 or so that we announced on the 8th of May, and within the next month or so we're going to announce several more. You can see that the law envisioned that we're in a space in our healthcare delivery that just isn't as good as what we could do, and the Congress gave us the funds to take that up a notch, and that's exactly what we're doing. And I can't imagine that everyone in this room couldn't touch somewhere one of these opportunities, but I think the thing that you have to keep in mind, and this is just kind of a depiction of this range of things, is people come to me and talk about stuff they want to do. For the most part, at CMS, we're pretty far upstream from where a lot of you might be working. So, for example, if you have an idea or you have a product that helps people manage their chemotherapy, well, we're probably not the customer for that product, but one of the people that are carrying out one of these innovations or one of the hospitals that's trying to improve their results, they are the natural customer for that product. What we're trying to do is change the marketplace in such a way that the people that take our benefit payments and our investments are aggressively out there looking for solutions and ideas to move them up the bar so that they can be successful in this program that we've put forward for them. And that's why we have this range of things that we're doing, some of which are related to the Affordable Care Act and some of which are related to other aspects of what we're doing in the Medicare program. So I don't know how much time, I think I have a minute. Excuse me?
What's ACO?
What is an ACO? Happy to describe that in more detail. ACO, the words stand for Accountable Care Organization, and what the concept is you know what a health plan is, right? You know what an HMO is. In an HMO, you've got a bunch of doctors, maybe you've got a hospital, and they take a single capitated payment, and then they worry about taking care of people, right? It's one way to pay for health care. The other end of the spectrum, you pay each time the doctor does something or the hospital does something. What we're trying to do is get some of the magic of that capitation program where the physicians and the other providers have an incentive to make the person be healthier rather than just churn more services by using the data that we have available now about the population of payments that those providers in the ACO see and make incentive payments available out of the savings that are generated by more efficient use of resources, which in the Medicare population usually amounts to preventing avoidable hospitalizations, each of which is very expensive. Yes, sir?
Okay, with the Supreme Court's decision looming now for June, what do you think is going to happen to the $1 billion that has been earmarked for the CMMI?
Okay, well, first of all, the CMMI actually has a $10 billion fund.
I'm sorry, the $1 billion that is right now allocated for this year, right? This first round.
You're talking about, you're specifically talking about the Partnership for Patients?
Yes.
Because there's a lot of different programs there, but in reality, CMMI has spent about $1 billion so far of that $10 billion. So I'm going to die someday, but when I woke up this morning, I wasn't thinking about it. I could die tomorrow, I could die 10 years from now. The Supreme Court could take the law away tomorrow or never. They could repeal the Medicare program. Lots of things are going to happen. What we do at CMS is the Congress passes laws, the President signs them, we write the regs, and we implement them. And we have absolutely no time to think about what might happen if they somehow change in the future. The one thing we know about every statute we have is that it will change in the future. So when we sit here and talk about the Affordable Care Act, the Medicare Modernization Act, the Government Performance and Results Act, and all these other things, they all actually become part of Title 18 of the Social Security Act and Title 19, and that's the, right, those are Medicare, Medicaid, those are the things that we're implementing. So we implement the law as it is now, it's all constantly changing. So the Supreme Court could change the game of the Affordable Care Act by repealing the whole thing, by repealing part of it, by changing some little piece of it, by making us eat broccoli. Lots of things are possible, but we don't know what those things are, so we just don't sit there and think about it. They could declare the law as completely unconstitutional, as if it had never been written, and then somehow I guess we'd have to find all the money that we've spent and get it back from the people we gave it to and give it back to the Treasury, which of course we wouldn't do. So if the whole law got repealed, then the Congress would have to produce some law to fix the gap between what happened and what didn't, but I couldn't begin to speculate how that'll happen. The one thing I can tell you is the money that's on the street today is on the street now, and if you're looking to get some of it, I would get out there and get it, because sitting there and saying I'm not going to go after it because it might go away is not going to be a good strategy. Anybody else? I didn't mean to take your question lightly at all. I just, who knows? I would give you my best guess, but there's other people from HHS here, and then they go back and tell the boss and I get fired. Although I am eligible to retire. You ever notice how when all these people, like those people from Chase Bank and all, or some bad guy, like the government does something, like they always retire. They get fired, but they're fine. I don't think that would work for me if I got fired. I'd be screwed. Come on, this is a lively group. I bet you some more questions. Yes, ma'am, in the front row. I'm going to walk out here.
I think part of the reason you're able to innovate and you're also able to track the patient challenges and better care is the fact that you have one health care system, right? And you have one website to, I've never been on the Medicare website. So one thing I wanted to understand, if government really want to move forward with the Affordable Care Act, what have you, and the previous panel, we heard all kinds of challenges, how we cannot integrate it and talk with one another. I'm going to ask a bizarre question. So can we then ask all these, whether it's the insurance company or the private care, to use the Medicare system as the default? They all ultimately have to feed into the Medicare system such that at least we now will have a system that will talk with one another.
So the question is, what can we do to get the convergence,
Exactly.
to get everything kind of plug into everything else? And I think we're actually kind of doing that. So One place where we're doing that is moving up to ICD-10. Okay, we're having a little trouble doing that. The physicians really pushed back hard and we delayed it. But having administrative data and claims on ICD-10 puts a lot more health, clinical related information into that, and the claims data is pretty much the same across the board because because we set a common set of diagnostic related groups of HCPCS codes, and so that exists. And I think the creation of under the ARA, the certification for electronic medical records will allow for some commonality there. We just published yesterday a request for people to help us define national standards for health information exchange. So I think there are a lot of things happening to do that. On the claims side already, claims cross over from Medicare to other payers because the HCPCS 1500 and the hospital bill are the same. So everyone wouldn't have to be on Medicare to get that kind of commonality, I don't think. Maybe I'm missing something in the question.
Well, but this is related to the patient's data, right? I mean,
Right.
I mean, claim is probably easier to deal with
Right.
because anytime when you deal with payment, people will get on with it. But in terms of the data analytics, the patient's data, where it's being captured, now the system is not talking to each other. So if people that use private insurance, you don't really get the benefit, right? So can there be a default system created instead of having everybody to create their own?
Well, but I think that is happening with this notion of, again, certified electronic health records that will begin to have, if they're able to talk to each other at some point, then there's a rubric of common definitions and data that becomes available. But I think that comes more from the provider side,
Exactly.
From our role. And I think certainly on the hospital side, we're seeing that start to happen.
Right.
Easier questions. Back.
You went through a lot of interesting initiatives. What can those of us on the technology side do to enable some of those, either from analytics, tooling, information exchange, capabilities? What are you looking for from those that have established in your organization?
Well, I think the first thing is, for example, I talked about those innovation grants that we did the other day. You can look at those. They're published online to 27 people and what they're doing. In fact, one of them's right here in Redwood City. It's a federally qualified health center. What's the name of it again? It's the collaboration between the San Mateo County Health Plan System and Ravenswood. Right. We're doing an event there with Congresswoman Eshoo on Tuesday. So, and what they're doing, as I recall, is a project around like health disparities. So the point is, you can look at the things that we're funding and say, what do I have on the shelf today, or what am I thinking about creating that enables success for people that are in this space, and then say, what's the fit to that? And then those are the potential people that you want to take your ideas to. Again, because we're not sort of buying that stuff straight on. We kind of see ourselves a little bit different. Yes, ma'am.
Yeah, judging from what you have, you're already at the award stage, so it's already done deal. There's no way to get in again. Second comment is, you do not consider total innovation of the new infrastructure for Medicare and Medicaid. You basically say basic system right now we have it, the Medicare and Medicaid the way it is. We want to improve upon, that's it, but no other big change. You do not entertain the innovation for total new infrastructure, even though it might be just clever maneuver or so of the. Anyway, I don't want to get into it, but what I'm trying to say is, look as if it's not. Look at.
Well, first off, Congress gave us $10 billion to invest in improvements in innovation, and we've only spent one of the $10 billion.
You are part of it. You are part of the.
We're the whole deal. CMS, it's CMS's money to spend.
You are the center for
Centers for Medicare and Medicaid Services,
Medicare
but we also
innovations.
do other. Well, I represent the whole Center for Medicare and Medicaid Services. The Innovation Center is just a piece of a small piece of our organization.
I see.
I'm the regional administrator. I guess I should introduce myself. So we got this outfit called the Centers for Medicare and Medicaid Services. It's the biggest budget in the government. It's bigger than the Defense Department.
Okay.
It's bigger than, I guess, I don't know, top 3 or 4 countries in the world. And it doesn't change on a dime. So it could be the case that throwing Medicare and Medicaid in the hopper and starting over again and having a much better system would be great, but the Congress would have to do it.
No. Innovations,
Yes.
it could be a different level. Right now, the level, looking at all nitty-gritty, nickel and dime, if you put a football player.
Right.
Nickel and dime stuff, you don't have total.
I see what you mean.
Okay?
Yeah.
So the upper level, and I read the financial report. In 2011, $546 million were spent for Medicare and Medicaid innovations. And I looked into it. There are only 18 innovations. In my opinion, that 18 innovations is really quite, plain. If not.
Well, that may have been true for that year's financial report, but as I presented here, there's quite a bit of innovation happening right now. We're going to be approving a lot more.
Innovation, but what I try to say is, it's a matter of course, innovations. It's not like very
Disruptive.
Right, I know what you mean. The government is not generally in the disruptive innovation business because disruptive innovation, somebody gets hurt, and it's very difficult for us to hurt people. I'm just kidding. I'll be here at lunch. Be happy to talk to folks more. Thank you so much for your kind attention and